Good morning. Today we are going to talk about a brief overview of caring for a psychiatric patient. To start off, we're going to talk about the different settings that people can receive mental health care, the types of admissions, and how people get involved in treatment through the psychiatric facilities. We're going to talk about how to apply the nursing process in mental health care. We'll touch on milieu therapy and cultural considerations when providing care for someone with a mental diagnosis. And then we're going to do a brief overview of the different diagnoses, ranging from depression all the way to substance abuse disorders. Lastly, we're going to wrap up with some communication techniques and then some activities and case studies. So, when we talk about different mental health care settings, we want to practice in least restrictive environment. And this is going to be the case for all nursing, whether it's for specific treatments or levels of settings. So, when we talk about mental health care, we always start our treatment with self care. That is the least restrictive intervention that we can do. And there's different things that we can do to promote self care. Generally, with psychiatric disorders, the most beneficial changes to self care that we can make are going to be those that involve exercise, sleep, and nutrition. But there's a wide variety of different self care activities that we can do with our patients, from building coping skills to helping them find rest, helping them build confidence, and building life skills, and a wide range of other interventions. If our patients don't respond fully to self care changes and changes to their lifestyle, and they still require further psychiatric treatment, we can refer them to outpatient services, which is going to be the next level um, of least restrictiveness. And in outpatient services, our patients may see social workers, case managers, counselors. They may go to group therapy, self led therapy, self help groups, and any wide variety of outpatient services. If a patient's symptoms continue to persist and they are severe enough that they're starting to interfere with the patient's ability to function on a wider scale, we can refer them to a partial program. In a partial program, our patients will attend the same therapies and treatments that you would get in an inpatient psychiatric facility. However, they're allowed to go home at the end of the day. So they would come to the hospital, they would attend all the groups, they would meet with a social worker, they'd meet with their psychiatrist, they'd go over med management and any variety of interventions that we would do in the hospital. But like I said, at the end of the day, they're able to return to their homes, and they're not considered a threat to their own safety or other safeties. Once a patient's symptoms become severe enough that we feel that it interferes with their own safety, with other safeties, or their ability to care for themselves in a way that can cause significant harm, then we would bring them to an inpatient hospitalization. Through an inpatient hospitalization, our patients typically stay anywhere from 5 to 12 days. However, there are some patients, depending on the severity of their illness and where they're being discharged to, um, placement, things like that, that may extend that hospitalization further. With inpatient hospitalization, the patients are there overnight and they are not allowed to leave. Even if they come in voluntarily, they still are considered in that lockdown unit. Other types of inpatient hospitalization is we have our hospital units, we have freestanding psychiatric hospitals, we have forensic units, which are used to treat for patients that have been um, convicted of a crime or accused of a crime. And forensic settings provide the mental health treatment while also preparing the patients to gain competency to stand trial or to serve their sentence if they've been ruled not guilty by reason of insanity. Other highly restrictive settings are going to be your group homes and your long term care facilities or residential facilities. And so, in these facilities, the patients may be there for life, they may be there for 3 months to a year. Um, However, it's not going to be considered as restrictive as inpatient hospitalization because a lot of times, if a patient's in a group home or a residential home, they have a little bit more freedom to leave the unit, to work jobs, to engage in socialization with family and friends, go to the movies, things like that. So, that is kind of how we structure our mental health care settings from least to most restrictive environments. So, when we talk about admission to an inpatient psychiatric facility, there's three ways that our patients can be admitted. The first way is voluntarily. So, in order for a patient to be admitted voluntarily, it is their choice. And so they would feel that they need hospitalization for treatment. They would come to the hospital and they would fill out voluntary paperwork. Once they fill out that paperwork, they are medically cleared, meaning they're evaluated to make sure that there's no medical cause for their psychiatric symptoms, and then they would be admitted to the hospital on the psychiatric floor. Like I mentioned earlier, once a patient is considered an inpatient psychiatric patient, they are not allowed to leave. Even if they come in and they say, "Hey, I feel like I need treatment," and then they get a good night's sleep, and the next day they wake up and they feel so much better and they feel like they don't need hospitalization anymore, they still cannot leave. It's considered a lockdown unit. If that is the case, someone that is admitted voluntarily can fill out what's called a 3-day letter. And this 3-day letter basically says that they no longer feel that they need treatment. And it gives their psychiatrist 3 business days to evaluate them and decide if that truly is the case. If the psychiatrist feels that the patient is not a threat to themselves or others, then they can release them after 3 days. If the psychiatrist feels that the patient still requires hospitalization, they can change that patient to involuntary status, which brings us to our next form of admission. An involuntary admission is usually against the patient's wish, or they do not feel that they need hospitalization. Because of this, we have to go through a lengthy legal process of petition and certification in order to get them admitted. So the petition form is something that anyone can fill out. It can be a family member, it can be a psychiatrist, a social worker, it can be, someone at the grocery store that's just checking that patient out with their groceries and everything. And so basically the petition form says why the person believes that individual needs hospitalization, what symptoms they're showing, and what criteria they meet for involuntary admission. So there's 3 criteria for involuntary admission. One is that they're a threat to themselves, they're a threat to others, or the severity of their illness is so severe that they're unable to take care of themselves in a way that it can lead to significant harm. Um, After they fill out that petition form, they can either bring it to the hospital or they can bring it to a court, and the um, judge will evaluate it and say, yes, okay, bring the patient into the hospital. If the person petitioning them are able to bring them to the hospital, that works best. However, if they're unable to, we can have what's called a police pickup, where they'll actually send a police officer to that patient's home and bring them to the hospital. Once they're brought to the hospital, they're brought to the ER, where they're ruled out for any medical causes of their psychiatric symptoms. And then they're evaluated by a psychiatrist. That psychiatrist looks at the petition form and evaluates the patient and sees if it matches. If they feel that it matches and the patient does need hospitalization, they fill out a certificate, a clinical certificate. Um, with that clinical certificate, the patient is now able to be brought up to the inpatient psychiatric unit. Once they're brought up to that unit, they're evaluated by a different psychiatrist who evaluates the petition form, the first certificate, and the patient. And if they are all congruent, they'll fill out a second clinical certificate. After the second clinical certificate is filled out, which needs to be done within 24 hours of the first certificate, the patient is considered fully admitted to the hospital. Um, the reason for this is so that we're not just putting people in a psychiatric facility for no reason because we're mad at them, because they annoy us, for revenge, things like that. This is to make sure that patients that are admitted to the hospital truly need to be admitted to the hospital. Once the patient is admitted involuntarily, they're set up with a court date because legally we cannot hold people in the hospital involuntarily for more than 72 hours without a court date set up. And this court date is not a criminal court by any means. It's called mental health probate court. And basically, what it does is it evaluates the patient's ability to care for themselves. So, in probate court, the judge will evaluate the patient, and if the judge feels that the patient is not able to attend to their healthcare needs on their own, they'll put them on a court order for treatment. And basically, what that means is for a designated amount of time, we can legally hold the patient in the hospital against their will. And the patient also legally has to comply with treatment, whether that means taking medications, following up with their outpatient appointments, meeting with their case manager, attending group therapy, things like that. Um, and so that is called the court order for treatment. After a patient is discharged from the inpatient facility, if they're on a court order for treatment, they still need to follow that treatment plan outside of the hospital. If they break that treatment plan for any reason, if they stop taking their medications, if they don't show up for their appointments with their case manager, then they're brought into the hospital under the third type of admission status, and that's called an existing order. Since they are already on a court order for treatment, we do not have to go through the petition and certification process all over again. Other reasons why a patient may be brought to probate court is to set up guardianship, which is kind of like a durable power of attorney, but more of a psychiatric um, approach. And so basically, the guardian is in control of making decisions for that patient. The patient has to be determined to be incompetent and unable to make those decisions for themselves. And if our patient has a guardian, then we have to get the guardian approval for any treatment changes, any med consents, and anything like that. Other reasons why people may be brought to probate court is to determine not guilty by reason of insanity and to determine if that patient is competent to stand trial in a criminal court. So, those are the different types of admission statuses. So, when we talk about the nursing process, it's the same as with any other healthcare field. We have our assessment, our diagnosis, our plan, our intervention, and our evaluation. Um, so, we're going to go ahead and break those down what we do for an assessment. With diagnosis is always going to be our nursing diagnosis related to, and that could be their medical diagnosis, it could be whatever conditions are happening, and then as evidenced by and the symptoms that support that nursing diagnosis. We're going to talk about the plan and how to set SMART goals. We're going to talk about the different interventions and how to make sure that they're evidence based. And then our evaluation is going to be referring back to those goals and seeing if those goals are met and if the patient has had good treatment outcomes based on our treatment plan. So, to start off with our admission assessment. So, when our patient is brought into the inpatient setting, which is going to be the focus for a lot of what I talk about today, since a lot of clinicals are actually on the inpatient setting. But in an admission assessment, we're going to do our psychosocial assessment. So we're looking at how their socialization is, how their interactions are with others, how their ability to socialize and interact is. We're looking at their emotional state. We're looking for any mental symptoms, which we'll talk about in the mental status exam on the next slide. And then we're going to do a physical assessment. Again, they have to be medically cleared to be brought to an inpatient psychiatric facility. But we just want to make sure that they don't have any medical issues going on that we're going to have to treat as well. So all of our patients are mentally stable, but it doesn't mean that they don't have physical illness as well. So if our patient comes in and they have diabetes, we're still treating that diabetes at the same time. If they have wounds, we're still doing our dressing changes. Just because it's a psychiatric facility does not mean that we stop treating any physical ailments that they may have. We're always going to ask our patient the reason that they're admitted. And whether or not it's the actual reason they're admitted gives us a lot of information. It lets us know if the patient has good insight and judgment, and it also lets us know what's important to that patient. And by asking them why they feel they're there and having that conversation with them, we're able to build rapport and relationship with our patients. We're also going to look at any diagnostic results, especially their lab work. A lot of psychiatric medications interfere with lab work or affect lab work, I should say. And we can also measure how compliant patients have been with their medications by measuring the medication levels in their blood. The last thing that we're going to do at admission is a body check. And so this is the form that's to the right, the picture of the person from the front and the back. And with a body check, you have to have two workers for accountability. And you're looking at every part of the patient's body for a couple of different things. One, you're looking for any injuries, any evidence of abuse, anything that may need to be treated in that sense. You're looking for any bug bites, if they have bed bugs or lice or maybe an allergic reaction. We would want to know all that. We're also looking for things like piercings and tattoos, which may seem a little silly, but patients may try and give themselves tattoos or piercings in the hospital, and we don't want to be liable for that. So if we have this baseline of this is how the patient was when they came into the hospital, then we can compare if anything comes up, or if the patient says, oh yeah, so and so hit me in the middle of the night, and you can do the body check again and see, oh yeah, they have an injury here. Did they have that when they came in? And if they didn't, you know that you have to investigate that further. If they came in with that injury, then you know that maybe it might not necessarily be something um, that's based in truth. So those are the different assessments that we do upon admission. Then each shift, you're going to do a mental status exam. And there's a lot of different formats for mental status exams, and different hospitals utilize different forms. But overall, they basically assess the same things. So they're looking at your appearance. They're looking to see if the patient is disheveled, if they're well kept, if they're having good attention to their hygiene. They're looking at the way that the patient talks, how their eye contact is, how their movements are, because a lot of movement can be affected by psychiatric medications. We're looking at their attitude and their mood and their affect. So, their mood is kind of the feelings that they have, where their affect is the range that they're able to show those feelings. So, if someone has a flat affect, they're not showing any emotion. If someone has a labile affect, they're showing a lot of different emotions. So, we're looking at that. We're looking at their cognition. How are they thinking? What is their thought process? What is the content of their thoughts? Are they having any hallucinations or delusional thought content? Are they having any suicidal or homicidal ideation? And when we do a suicidal or homicidal assessment, we always want to be very direct. We want to ask that patient specifically, do you have thoughts of wanting to kill yourself, or do you have thoughts of wanting to kill someone else? A lot of times that's an uncomfortable question to ask. So people will ask, do you have thoughts of wanting to harm yourself? And technically, that is not evidence based, because what we find is when people feel suicidal, they don't consider it as harming themselves. They see it more as ending the pain. So we want to be very clear and very direct. If they do have thoughts of wanting to kill themselves, we want to know, do you have a plan? Do you have the means to carry out that plan? How likely are you to carry out that plan? Um, is there anything that stops you from carrying out that plan? And their response to these questions helps us to drive our interventions and drive our precautions to make sure that we're keeping that patient safe while they're hospitalized. Other things that we're going to assess with the mental status exam is their behavior, as well as their insight and judgment. We may also assess things like their memory and concentration, their orientation, um, and their ability to do things like follow directions, interact with others. So, like I said, you'll do the mental status exam every shift on the psychiatric unit. So, then we move on to our plan. And with our plan, when we set goals with our patients, we want them to be in SMART goal format. And so, what this means is that the goals are specific, measurable, attainable, relevant, and time bound. So, for example, if your patient comes in with depression and their goal is to buy a car, that may be a good goal and it may be a goal that they need, but it's not necessarily relevant. It's not necessarily time bound. So that wouldn't be considered a good treatment goal because it's not a SMART goal. Um, for that same patient, an example of a SMART goal would be that the patient reduces their depression from a 10 to a 6 by the end of the week. That's very specific. We know that we're reducing their depression. It's measurable because we can ask that patient on a scale of 1 to 10, how severe is your depression? If it's 10 at the beginning of the week and 6 or lower by the end of the week, then we know that they've reached that goal. Is it attainable? Yes, we can reduce the depression by that amount in a week. If a patient comes in and says, I have depression rated 10 out of 10, but I'd like it to be 0 by tomorrow, that's not necessarily attainable or realistic. Um, and then we want to make sure it's relevant to why the patient's there, that it matches their treatment needs. And then we want it to be time bound. So we want to have a specific date that we can look at and see if that goal has been reached. So it could be by the end of the day, it could be by the end of the week, it could be by the time of discharge, it could be in the next month. So you always want to have that time parameter when you're setting goals with your patients. So then we can talk about different interventions. A big intervention that we use quite frequently in psychiatric nursing, and it's a very flexible and creative approach to healthcare, is coping skills, helping our patients build strong, beneficial, adaptive coping skills. And so, basically, what a coping skill is an activity that someone can engage in to help mitigate stress, help them solve problems, and help them feel better overall. There are such things as maladaptive coping skills, and these are coping skills that are not beneficial to the patient, or they may cause more harm than good. So, examples of this would be things like smoking, excessive substance use, or alcohol use. Um, and then there's different coping skills that may be good for one patient, but they may be maladaptive for another patient. So, for example, exercise is an incredibly good coping skill for a lot of people. But if someone has an eating disorder and they don't have the caloric intake or the nutrition to sustain um, exercise, exercise could be a maladaptive coping skill for that patient. So we always want to kind of keep that in mind, and we always want to help our patients build coping skills and use coping skills. Just like with the healthcare settings, we always want our interventions to be least to most restrictive. So we always start off with that coping skill. If our patient has anxiety, we're not going to jump right into, oh, here's a medication for that. We're going to try and encourage coping skills first. We're going to ask them, did you journal? Did you go for a walk? Do you need to talk about it? And kind of help them in that way. Um, we'll go through the different pharmacological therapies, but psychiatric medications are called psychotropic medications. And there's different classes of them that treat different illnesses. A lot of psychotropic medications have very severe side effects. So, medication compliance is a big issue when it comes to psychiatric diagnoses. So, we'll kind of talk about that a little bit as well. As far as non pharmacological treatments for psychiatric disorders go, we have ECT, or electroconvulsive therapy. And what this is it's the top right picture. But basically, what we do is we give the patient muscle relaxant and anesthesia so they are not awake during this time. We hyperoxygenate them to make sure that they aren't oxygen depleted during the treatment. And then we put an electrode either on both sides of their head or on one side of their head. And we send electric pulses through the brain. What this does is it causes the patient to have a seizure. And we don't necessarily know why this works, but it is something that has been done for years, and it's found to be effective in treating a lot of things like depression, bipolar disorder, certain personality disorders. Um, and typically, it's a very safe treatment, and the patient is monitored the entire time. Patients will usually get ECT 3 days a week for 4 weeks, and then they can get maintenance ECT, which means that they're getting treatments once a month. Um, TMS, or transmagnetic stimulation, is kind of a more modern form of ECT in the sense that it's a newer treatment and it has similar outcomes to ECT, but it's less invasive. So, what this is it's the bottom right picture. And what we do is we put a magnetic device on the patient's brain, and we send magnetic pulsations through the brain. So they get pulsations for 45 seconds, I think it is, and then a 15-second break, or maybe the reverse. And they have this treatment for an hour every day for 30 days. And again, this is used to treat things like severe depression, bipolar disorder, and personality disorders. Because this is a newer treatment, a lot of insurance companies don't necessarily cover it, so it's not as accessible to a lot of people. Other types of non pharmacological therapy we can do is phototherapy. So that's when we have our patients sit under a light for a certain amount of time a day, anywhere from half an hour to 4 hours a day. And that helps them to process vitamin D better, and it can reduce symptoms of depression and anxiety. Lastly, we have EMDR, or eye movement rapid desensitization. And this is used for patients that have had trauma. And basically, what it is we um, work them through some of their experiences to trauma to desensitize them in a way that's considered safe and non-traumatizing to that patient. So it may be that maybe they have to watch a swinging pendulum while we flash different images of the trauma behind the pendulum. So they're focused on that pendulum, but subconsciously they're exposed to that trauma so that they can become desensitized to the reaction that they have. Lastly, we really practice milieu therapy. It's one of the centers of psychiatric nursing. So we're going to talk about that on the next slide. So, milieu therapy is basically treatment of the environment to make sure that it is a strong, healing, and safe environment for our patients. So, when we're practicing milieu therapy, we're looking at three things. One, is it safe? We always want to make sure that our patients are in the safest environment possible. And something that may be safe for one patient may not be safe for another patient. So, we always want to evaluate that and check that. Different examples would be like, in a medical floor, you have your vital sign carts out in the hallways. On a psychiatric floor, you can't do that because a patient could use that cord to wrap around their neck, um, and things like that. So, in psychiatric nursing, you want to be very aware of the environment. You want to be very aware of what could be safety hazards and how you can fix that. The second piece is it a healing environment? In order to be a healing environment, it has to be aesthetically pleasing. It has to have good resources and it has to meet the needs of that patient. So, the example that I always kind of like to use for this one is if you're trying to study for an exam and you're losing focus, you're getting tired, maybe your room's really messy, so you're starting to get really stressed out. If you clean your room and light a few candles, it's often easier to study because you feel like you're in a more positive environment. So, same goes for the patients. We want to make sure that they have pictures on the wall, that they have nice furniture, that they have nice things visually, that they have good resources to meet what they need, that they're in a clean environment. And that will help them to cope with their symptoms and have good outcomes of their treatment. And then lastly, we want to make sure that it has supportive social interactions. So in psychiatric nursing, it's kind of like a dorm room for an inpatient facility where the patients have their bedrooms, but they're walking around the unit all day. They go to groups in different classrooms. They have a cafeteria where they all eat together. They have, television rooms and activity rooms that they can be in at any time of the day. So there's a lot of interaction with other patients. They're not confined to their bedroom. And because of this, we have a lot of positive as well as negative social environments, and it can be really helpful for patients to have positive social interactions. Some of the negative social interactions would be things like inappropriate relationships on the unit. And while we want to encourage that they build their self esteem and have strong relationships with others outside of the hospital, we don't want inappropriate relationships to become a distraction to their treatment. Um, we also have patients that might not get along. And when patients don't get along, they're at risk for arguing, for fighting, and that can create a very tense environment that can not only exacerbate the tension for those two individuals and place them at a safety risk, but it can also make other patients uncomfortable or put other patients at safety risk. So, whenever we sense that there's conflict between two patients, as nurses, we have to practice that conflict management and make sure that we are mitigating and de escalating any potentially dangerous or harmful situations. The last maladaptive social environment that we have is called mothering. And this is when a patient focuses so much on taking care of the other patients that they're not taking care of themselves. So, those are all different social situations that as a nurse we may need to intervene in. There's a lot of different aspects to milieu therapy as well. So on the right, I have a picture here of the floor plans for an insane asylum. And I'm sure that you guys know that we no longer use insane asylums, but the actual structure of the asylum was very beneficial and practiced milieu therapy very effectively. So as you can see in the picture, each unit has its own kind of section, and all four walls have access to the outside. So there's windows on all four walls of each unit. And this is important because we know from studying Florence Nightingale's work, we know from understanding milieu therapy that sunlight is very important. A lot of these patients, especially if they're on a psychiatric unit that's inside a general hospital, may not have access to a lot of sunlight or fresh air. A lot of times they're unable to go outside. And if these patients are in the hospital for 3 months, you can imagine how taxing that would be emotionally and physically to not be able to feel sunlight and not be able to breathe fresh air for 3 months at a time. Um, Other things that asylums did that was very beneficial is they made sure that they used top of the line furniture as well as a lot of beneficial decorations because they did find that patients that were in an environment that they felt was attractive helped motivate themselves to take care of themselves better. And so that kind of brings me to another point. A lot of times in a psychiatric unit, the staff do not wear scrubs. A lot of times they'll wear business casual clothing. Um, and some hospitals are kind of going away from that, but part of that is because it reduces the white coat syndrome in patients and it helps them to better trust and open up to their nurses and healthcare staff. But also, it motivates the patients to make sure that they're taking their showers, that they're brushing their teeth, that they're getting dressed every day. So, those are all different aspects of milieu therapy. And like I said, this is a very, very, very important concept to psychiatric nursing. So, the last thing that I want to talk about before we get into the different diagnoses is cultural and linguistic competency, or sometimes called humility. And basically, what this means is that we are offering respect and resources to our patients' cultural beliefs and making sure that they have the ability to practice those. Linguistic competency is making sure that the patient can communicate with others. Um, and this may be making sure that they're able to have a proper translator so that they can interact with others, understand what's going on in the groups, communicate with their psychiatrists and whatnot. But there's also other language barriers other than not speaking the same language that we would want to make sure we address to maintain linguistic competency. So that might be things like if our patient is hard of hearing, that we're providing them with the resources that they need. If they're blind, how can we make sure that they can read what's on the board and things like that? We want to make sure that if our patients are having psychosis, that can be a barrier to effective communication. So, all of those different things we want to think about, and we want to do what we can to help mitigate those barriers. And that's practicing linguistic competency. Same with cultural competency. And when we talk about cultural competency or humility, we always want to ask the patient directly what their cultural and religious beliefs and needs are. Because just because a patient belongs to one cultural group does not necessarily mean that they share the same beliefs. So it's really important that we get directly from the patient what they need provided for them. In psychiatric nursing, sometimes practicing cultural humility can be more difficult than it would be in other settings. And the main reason for this is safety. So, an example of this, which I have to the right, is the rosary. So, the rosary is something that's used in the Catholic faith by a lot of people, and it's a way to pray. Um, but as you can see, it's got the crucifix on the end, and that crucifix can be very sharp. It can be used to cut yourself, it can be used to hurt yourself. And also, since it's a string of beads, it's something that a patient can wrap around their neck. So if a patient is Catholic and they let us know that using the rosary is something that's important to them, we don't want to discourage them from using the rosary, but we want to make sure that they're able to use it in a safe setting. So, different ways that we can accommodate this is we may have to lock up their rosary, and when they want to use it, they have to use it within view of staff so that if they do use it to hurt themselves, staff's there to intervene. We could do things like those pull apart beads, which is the top picture where it's stringless. So if they do wrap it around their neck, they it will just detach and they're not able to hurt themselves. We could do things like finding a paper rosary for them. So there's a lot of creativity in our interventions with psych nursing and in the way that we can practice cultural and linguistic competency. So think about that when you're working with your patients with psychiatric disorders. So now on to the actual disorders, and this is just going to be a brief overview. So the first one is depression. Depression is one of the most common psychiatric disorders along with anxiety, and it's experienced by I believe it's 1 in 5 people at any given time. So the DSM-5, which is our diagnostic statistical manual that helps define the different symptoms and criteria for psychiatric disorders, states that individuals with depression have to have at least 5 of the 9 symptoms listed here, with at least 2 of them being loss of interest and pleasure and depressed mood. So the other 3 or more symptoms could be feelings of guilt, low self-esteem, disturbed sleep, which could mean more sleep or less sleep, disturbed appetite, again, eating more or lack of appetite, low energy, poor concentration, or suicidal thoughts and ideations. And they have to experience these symptoms over at least a 2-week period. So, when we treat depression, the medications that we can provide them are antidepressants. And antidepressants work on the neurotransmitters that cause depression. So, that's going to be your serotonin, your dopamine, and your norepinephrine. Serotonin is the main neurotransmitter involved in depression. So that's going to be the main focus of the antidepressants. So our SSRIs, or our selective serotonin reuptake inhibitors, basically aim to make more serotonin available for those patients. Because it's just working on one neurotransmitter, they tend to be very effective, but also have less side effects than some of the other classes of antidepressants. So our SSRIs are always going to be our first line therapy for depression. If our patients don't necessarily respond as positively to an SSRI as we'd like them to, we can provide them with an SNRI, or a serotonin norepinephrine reuptake inhibitor. So now these medications work on 2 neurotransmitters. So they do typically have more side effects, but they can also work more effectively. If those don't work, we can move on to our tricyclic antidepressants. Tri meaning 3, so it works on all 3 neurotransmitters. Again, this can have more effectiveness, but it also tends to have more severe side effects. When we talk about side effects for antidepressants, the most common ones are going to be things like significant weight gain, sexual dysfunction, um, hypersomnia, meaning they're very tired and they want to sleep a lot, headache, nausea, things like that. The last class of antidepressants, which typically aren't used very frequently nowadays because they have a lot of drug to drug and food to drug interactions, are MAOIs, or our monoamine oxidase inhibitors. The reason why we still include this in psychiatric courses is because it typically tends to be a strong NCLEX question because it has that unique interaction with foods. And so basically what happens is if you have a patient that's taking an MAOI and they also take tyramine, or they eat foods with tyramine in it, I should say, they can develop what's called hypertensive crisis. And hypertensive crisis is when their blood pressure reaches very dangerous levels that can lead to things like stroke and death. So, again, you want to avoid using MAOIs, but if you do, you want to discourage the patient from eating foods with tyramine. And that could be things like aged cheeses, fermented fruits, alcohol, red meats, beans and legumes. Um, and just different variety of foods. Non-pharmacological treatments that we can use for depression, again, is our coping skills, our ECT, our phototherapy, and our transmagnetic stimulation, which we've already talked about. Actually, going back, one more thing I do want to say about the medications for antidepressants is they typically take 4 to 6 weeks before they're fully effective, and they generally start treating the physical symptoms of depression before the mental symptoms of depression. So if you have a patient that has suicidal ideation, they may want to kill themselves, but they don't have the energy or the focus to really think and carry out a plan at that time. So even though they have suicidal ideation, they may be low risk for suicide. Then, when you start them on an antidepressant, between weeks 2 and 4 of starting that medication, they suddenly start finding that their energy is improving, their focus is starting to improve. So, at this point, their emotions may not have improved all that much. So they may still have that suicidal ideation. And now they suddenly have the energy and the focus to create and carry out a plan. So if you've ever listened to the drug commercials that say, this is an antidepressant, but no, it may increase risk of suicide. That is why. So, our patients between 2 and 4 weeks of starting an antidepressant are going to be considered high risk for suicidal behavior. So, we definitely want to educate them on that and we want to monitor them for that. Um, a lot of these medications are also um, included as having risk for withdrawal. So they don't want to be stopped abruptly. And if a medication is not working for a patient, we have to wean them off that medication to prevent any symptoms of withdrawal. So if you are someone that is struggling with depression and you start an antidepressant and it takes 6 weeks to find out if it's working, and then you find out it's not working, so then you have to take a week or two to wean it off, and then you have to start another antidepressant, wait another 6 weeks to see if it works. It can be a very tedious, exhausting, and emotionally draining process. So they have created what's called PG4 testing. And this hasn't been approved by a lot of insurances yet because there's mixed information on the effectiveness of it. Um, but basically, what that testing is it looks at your genetics to see what antidepressants you'd most likely respond positively to so that they can start you on that antidepressant right away and try and avoid the potential years of trial and error and starting an effective antidepressant for that person. So now we have anxiety. Anxiety is the most commonly experienced psychiatric symptom, but depression is the most commonly treated. So anxiety can be positive or it can be negative. There's 4 different levels of anxiety: mild, moderate, severe, and panic. And mild anxiety is considered beneficial anxiety because it either motivates us to do something or it prevents us from doing something that could be harmful. So, anxiety is a feeling of discomfort that a lot of people experience. So, for example, with mild anxiety, you may have a patient that's walking on a hike. As they approach the edge of a cliff, they're going to feel increased anxiety. That causes them to stop walking so they don't walk off the cliff. Kind of conversely, maybe you have somebody that is in school and they're studying for an exam. As the exam date approaches, they may experience more and more anxiety. That anxiety then motivates them to study so that they feel more prepared for that exam. So, that is mild anxiety. It is beneficial for us and it does not require treatment because we want to feel mild anxiety when it's appropriate. Moderate anxiety is when that anxiety is a little bit out of proportion to the actual situation. And it may interfere with our life a little bit, but generally, moderate anxiety can be treated by non pharmacological therapies like coping skills and deep breathing techniques, things like guided imagery, which is where you would close your eyes and pretend you're on a beach and focus on your 5 senses. What are you hearing? What are you smelling? What are you feeling? What are you seeing? So, that is kind of an overview of moderate anxiety. Severe anxiety is very much out of proportion to the situation, and it can very severely interfere with the person's ability to function at work, function socially, function in school, function with their ADLs. And it typically requires pharmacologic and non pharmacological treatment. So we call that combination therapy. Um, Antidepressants are first line therapy for general anxiety. So again, you want to make sure that you're monitoring those patients for the side effects, for any suicidal ideation between weeks 2 and 4. But that's what we're going to start them on. And then we can also do different things like our non pharmacological therapies. The highest level of anxiety is panic or panic disorders. So, when someone's having a panic attack or panic level anxiety, they're going to have a severe increase in their heart rate. They may feel flushing, they may feel sweating, they get short of breath, so then they start to hyperventilate. As they hyperventilate, they release too much CO2 and it messes with their acid base balance in their blood. So then what happens is they start to develop numbness and tingling in their hands and their feet, and they may start to cause them to panic even more. At that time, they can also develop dry mouth, headache, severe stomach pains, nausea, vomiting, develop diarrhea. They're going to have a lot of muscle tension, and their muscles may start to tremor. They may start to shake. They may start to fatigue. The patient is going to have an inability to relax. They're going to feel like they're dying. A lot of times, a lot of patients that are having panic attacks actually think they're having a heart attack. So they go to the ER because it presents very similarly. Their focus is going to be very hyper focused on that feeling of doom. So they may not be aware of their outside surroundings. They may not respond if you try talking to them because they're so stuck in that feeling of panic. So when our patients are having a panic attack, we want to first and foremost control their breathing. Once we prevent that hyperventilating, their muscles will start to relax. They'll start to get feeling in their hands and their feet and their face. Their heart rate's going to decrease a little bit. And then after we reduce their anxiety to a certain level, then we can help them work on their coping skills and things like that. A lot of times, because they're in that panic state and they don't have the ability to concentrate on what you're saying, you need to be very direct with them. So when we're controlling their breathing, we have to say, breathe in, breathe out, hold your breath, things like that. Another easy way, if your patient is not an aspiration risk to control their breathing, is to give them a sip of water because that causes them to stop breathing and it resets their breathing while they swallow. Um, if our patients are not able to focus on our guided deep breathing techniques, or if they are an aspiration risk and we don't know how to control their breathing, we can provide them with a benzodiazepine. So that's like your Ativan, your Valium, your Xanax, your Klonopin, and those are effective in reducing anxiety quickly. These medications are often very addictive, so they are only used as PRN for panic related incidences. If you have a patient that has severe anxiety or panic, but has substance abuse issues or doesn't want to take benzodiazepines, we can give them Boost Bar, although Boost Bar doesn't work as quickly as a benzodiazepine. Other symptoms of anxiety, just in general, other than the physical ones that I already talked about, is these individuals often have excessive worry. They may be irritable, impatient, feeling on edge. They may have a lot of fatigue. They often have vivid dreams. They may have racing thoughts, or their mind might go blank a lot. They have a hard time making decisions. They may have poor memory, and they may try and avoid things that cause them severe anxiety. Other anxiety related disorders are things like trauma disorders. So that's your PTSD and your acute stress disorder. With PTSD, it usually takes about 3 months after the trauma for the patient to start developing symptoms. And they often have symptoms of anxiety, irritability, intrusive thoughts and behaviors. Um, and they're at high risk for things like substance abuse, suicidal ideation, and things like that. So, our trauma disorders generally take a lot of combination of different therapies and different medications and desensitization to that trauma. And like I mentioned earlier, we can use EMDR for that. Um, Obsessive compulsive disorder is another anxiety related disorder, and that is when the patient has obsessive thoughts that are so uncomfortable and interfere with their ability to focus and to live functional lives. And so, what they do is they engage in compulsions or behaviors that reduce those obsessive thoughts. A lot of times, the obsessions and the compulsions will match. So, if someone is having a lot of obsessive thoughts about getting sick, they may wash their hands frequently. If they have obsessive thoughts about having someone break into their house, they may check their locks frequently. In order to be diagnosed with OCD, the compulsions have to take up at least an hour of their time each day. Our main treatment for OCD is going to be antidepressants, but we're going to give them at a much higher dose than we would for anxiety or depression. So these patients are going to be at a much higher risk for suicidal ideations as well. And then lastly, we have our somatoform disorders. And these are when people have such emotional distress or trauma that their body physically cannot mentally cope with it. So they start experiencing those symptoms physically. So this is your patients that could range anything from having excessive headaches or stomach aches when really they're experiencing depression or anxiety, all the way to you may have patients that develop urinary retention or paralysis because of the traumas that they experienced. There's no biological basis for why they have those physical symptoms, and any diagnostic testing you do are going to come out negative because the root of the physical cause is the emotional trauma that they're experiencing. And somatoform disorders take a lot of therapy and a lot of shifting the focus from the physical symptoms to the feelings in order to treat that effectively. Other anxiety treatments that we can do is panic control therapy. So, with panic control therapy, what you would have is this is more common for patients that have panic attacks frequently, but you would have them engage in some type of physical activity, whether it be going for a walk or running on the treadmill. Because when we engage in physical activity, we experience a lot of the physical symptoms of a panic attack. You're going to have that increased heart rate, you're going to have that flushing and sweating, the feelings of shortness of breath. Um, you're going to have that muscle stiffness. And so once you experience those physical symptoms, they walk you through different relaxation techniques. So they may say, okay, you've ran a mile. How are you feeling? Okay, now try and breathe in through your nose, out through your mouth, and control your breathing. Okay, now try and relax your muscles. And what that does is it helps your body build that muscle memory so that when you are experiencing a panic attack, it can kind of start to calm itself down without your conscious awareness of that. And then the other type of anxiety related therapy that we can use for anxieties and phobias is exposure control therapy. And so, with exposure control therapy, we're going to expose the individual to the thing that causes them anxiety in hopes to desensitize them so that when they are exposed to it um, in an unsafe setting or a setting outside of their treatment facility, they don't have as strong of a reaction to that. And with exposure control therapy, we want to slowly ease our patient into desensitizing them to what is most anxiety provoking for them. So we may have them identify 5 things that cause them anxiety. And then we work on the thing that causes the least amount of anxiety and teach them coping skills and how to kind of desensitize themselves from that. Once it gets to a point that that thing really doesn't cause them a lot of the symptoms of anxiety, we can move on to the next level until we have fully desensitized them to all the things that cause them anxiety. So, next we have bipolar disorder. And bipolar disorder is a mood disorder that is an alteration of different mood states. One of them being depression, which we talked about, and the other one being mania. So, mania is a feeling of elevation, euphoria. The patients are often expansive, potentially irritable. They often feel really high self esteem to the point that they can develop grandiosity or grandiose delusions. And that's when they have an inflated sense of self beyond their actual capabilities or interactions. So these are going to be your patients that may feel that they have connections to famous people, or maybe they are famous, or they have these superior abilities to do different things that they might not actually have those superior abilities to do. Um, these are your patients that say, oh, yeah, I'm actually just here in the hospital because I own this hospital and I'm checking on the staff, when really they don't own the staff. So, those are all symptoms of kind of grandiose delusions. With mania, the patients may be hyperverbal, meaning they're talking a lot, and they may have pressured speech. They often engage in pleasurable or risky behaviors because they feel invincible and they enjoy it. And they also tend to have much increased focus and they can be very purposeful and goal directed. So, some patients that are having a manic episode can be very productive. I've known patients to write a whole book in a manic state. I've known patients to build a house in a manic state, but it's not sustainable. They have decreased need for sleep. So, the more manic they become, the less they sleep, the less they eat, the more severe the mania gets. And it eventually gets to a point where they're having psychosis, they're really dangerous to themselves or others. Those risky behaviors get more intense. They may be spending a lot of money, they may be doing a lot of drugs and things like that. So, even though patients thoroughly enjoy being manic, it can be dangerous if it's not treated. The different types of bipolar disorder is bipolar 1 disorder, when the patient has manic episodes as well as depressive episodes. Bipolar 2 disorder is less often diagnosed because the patient has depressive episodes, but they also have hypomania. And hypomania doesn't quite reach the point of mania. Oftentimes, these patients just experience that increased focus and purposeful goal directed behaviors and the elevation in self esteem. It's very functional. It oftentimes does not interfere with their ability to function or sleep or eat or anything. So, bipolar 2 disorder can be misdiagnosed as just being depression or non diagnosed. Mixed bipolar disorder is when the person experiences mania and depression at the same time, which may sound confusing because they're kind of opposites. But what happens is they have the depressive thoughts and feelings with the energy and the irritability and the pressuredness of mania. And so these patients are actually at highest risk for suicidal behaviors. Rapid cycling is when our patients experience at least 4 different mood states per year, meaning they have 3 depressive episodes and a manic episode, or 2 manic and 2 depressive episodes. Um, a lot of people think that with bipolar disorder, you may be happy in the morning, sad at night. That's not the case. When these patients have mood states, they often last 2 or 3 weeks, and they may go years without another mood state. But with rapid cycling, they have at least 4 episodes per year. And then our patients can also be diagnosed as bipolar with psychotic features. Our main treatment for bipolar disorder is going to be lithium. Lithium is in the salt family, so it competes with salt in our body. And when our patients take lithium, we really want to make sure that we're monitoring their lithium level so they don't develop lithium toxicity, and that we're also encouraging them to maintain a good water and salt intake so that we don't change that too much. Because if our patients stop drinking a lot of water, their lithium level can increase and then they can develop lithium toxicity, which is considered a medical emergency. Or maybe they start drinking too much water and their lithium level drops to a subtherapeutic level. So then they can have another mood state episode. Lithium typically works in about 60% of patients. For those patients that it doesn't work in, we can provide them with a mood stabilizer. So, our mood stabilizers are anticonvulsant medications that we use for seizures. But when they're used for bipolar disorder, we call them a mood stabilizer. So, this is going to be your things like Depakote, Lamictal, Keppra, Seroquel, all of those different medications. A lot of our mood stabilizers also need lab monitoring when we give them to our patients to make sure that they're a safe and therapeutic level. In addition, we're also going to assess for any safety issues, any family needs, any physical needs, and financial needs, especially when they're in that manic episode. Their pleasurable or risky behaviors may severely impact their finances. It may impact their family relationships. So we may need to do family therapy. We may need to, get them a payee, which is someone that is in charge of their finances. Physically, if someone's manic, they may be malnourished. I've had a patient once that walked from Chicago to Grand Rapids in a manic state, and they had a lot of skin breakdown on the bottom of their feet. So we would want to assess their skin breakdown, their muscles, all of that to make sure that they're physically being treated as well. And in the bottom right corner, you can see a pendulum there that signifies the progression of bipolar disorder. So each time you have a mood state, it kind of swings further and further on the pendulum, and it's harder for the person to stay there in the middle. So somebody may have the genetic predisposition for bipolar disorder, and they may go most of their life asymptomatic, and then maybe in high school they have their first breakup, so they develop just a little bit of depression, so it swings just a little bit on that pendulum. But after a while they're able to recover with coping skills, they don't need any medications or anything, and then maybe they go to college and they have their first all-nighter studying for a test, and maybe they develop mania. So the mania is just a little bit, not too much. They fall asleep, they get a good night's sleep, they return back to their baseline. Well, the next time that they're going to be depressed, it's going to be more severe depression, and it may require more interventions to try and get them back to that baseline. They may have to start medications, they may have to, start seeing a therapist, things like that. And so medication compliance is going to be really, really beneficial for patients with bipolar disorder because it helps prevent those progressive mood states that become more and more severe and require more and more treatment to get back to their baseline. So now we have schizophrenia. Schizophrenia is symbolized by positive and negative symptoms. Your negative symptoms are going to be very similar to depression, where your positive symptoms are going to be things like hallucinations, delusions, and some behavioral and thought changes. So the way to think of that is negative is like less than or subtraction. So it's things that typically you would see in somebody without schizophrenia, but when someone is having a schizophrenia symptoms, they don't have that. So it's like they don't necessarily have the energy, they don't have the social focus, they might not have an appetite, things like that. Where positive is like addition. So it's in addition to what a normal, or I shouldn't say a normal, in addition to what someone without schizophrenia has. So it's seeing things that aren't there, it's hearing things that aren't there, it's having thoughts that aren't rooted in reality. So the different types of hallucinations focus on your senses. So you have auditory hallucinations, which are hearing voices. They can be command auditory, meaning that the voices are telling you to do something. You can have visual hallucinations where you're seeing something, tactile hallucinations where you feel something. A lot of times it's like bugs crawling on them or needles poking them, or it can be like sexual stimulation without engaging in any sexual acts. You can have gustatory hallucinations where they taste something that's not there, or olfactory hallucinations where they smell something that's not there. As far as delusions go, you can have grandiose delusions, which we talked about with bipolar disorder. You can also have paranoid delusions where they feel that something bad is happening, someone's out to get them, things like that. A lot of times, if they feel someone's out to get them too, we can call that persecutory hallucinations. Our patients can have religious delusions where they either feel that they are a religious deity or a religious deity is talking to them or controlling them outside of their normal cultural beliefs. Um, they can have um, aromatic delusions where they feel that they have connection to someone or a strong relationship with someone that they might not. Um, and there's a bunch of different types of delusions. So, those are kind of the positive and negative symptoms of schizophrenia. We treat schizophrenia with antipsychotics, and there's two different classes of antipsychotics. You have your first generation antipsychotics, which only treat the positive symptoms. They are older medications and they have very, very, very severe side effects. The main ones being EPS or extrapyramidal symptoms. And these are things like tardive dyskinesia, akathisia, oculogyral crisis, um, pseudo Parkinsonism. So it's a lot of motor or in dystonia. It's a lot of muscle impairment. It's a lot of shaking. It's a lot of discomfort for that patient. EPS, if it's treated early, can be resolved, but if it's not treated effectively early on, it can be permanent. The way that we treat EPS is with an antihistamine like Cogentin or Benadryl. NMS is a medical emergency associated with antipsychotics, and this is when the patient starts developing muscle tightness, and it kind of starts in their jaw and their hands, and they start getting muscle tightness there, so they might not be able to move their mouth, their tongue kind of swells, and if it's noticed early, again, just giving them a shot of Benadryl or Cogentin can be effective in treating that. But if it's not, that muscle contraction is going to become progressive. And eventually, all of their muscles are going to tense up and it's going to produce body heat because as our muscles are contracted, they produce energy, which produces heat. Our body can only sustain and regulate our temperature up to a certain amount. So, what happens is the patient then starts to sweat, they start to get nauseous and vomit, and all these different things to try and lower that body temperature that's caused by that muscle contraction. But that muscle still is not relaxing, so it continues to build that body heat, and it can lead to things like going into a coma, having seizures, and the patient can die from this. So it is really important that if a person is on an antipsychotic, that they're also given antihistamines and that we're monitoring for EPS and NMS. Second generation antipsychotics treat both the positive and negative symptoms, and they tend to have less side effects, but the side effects are still very, very, very severe. Um, a lot of patients that take a second generation antipsychotics also have to take things like metformin or other anti-diabetic medications because it can cause type 2 diabetes from severe weight gain and very quick weight gain. It can cause a lot of sexual dysfunction. You can still have a lot of those EPS type symptoms. So patients that have schizophrenia and are getting treatments with antipsychotics, a lot of times don't want to take the medications because the side effects are so severe. Another reason that patients may not want to take these medications is because if they're having paranoia or hallucinations, those hallucinations and the paranoia may be telling them that their medications are poisoned or that they shouldn't take them or that there's a microchip in them and different things. So medication compliance is a major goal for someone with schizophrenia, but also a very hard task. So, what they've done is they've actually created long acting injections where the patients get a shot every 2 to 4 weeks of that antipsychotic, and it's released slowly over time. So, they don't necessarily have to take a pill every day. And then we have our personality disorders. Personality disorders are organized into clusters, and they're disorders where someone's personality traits become so pervasive that it starts to interfere with their abilities to function. So, our cluster A disorders are odd or eccentric disorders, and this is paranoid personality, schizoid personality, and schizotypal personality. Um, Without going too in depth with them, I'm just going to say that our main nursing goals for treating someone with a cluster A disorder is to help them find joy in life as well as the ability to socialize and communicate with others. With personality disorders, we typically don't use medications. We focus a lot more on therapy, but cluster A disorders sometimes can benefit from an antipsychotic. Our cluster B disorders are our dramatic or unpredictable disorders. And this is antisocial personality disorder, borderline personality disorder, histrionic personality disorder, and narcissistic personality disorder. Um, with antisocial personality disorder, these patients have a strong need for control and manipulation, and they often don't feel remorse for the way that they treat others. So, these individuals can often be very manipulative towards others, they can be very hostile. Um, and a lot of times, antisocial personality disorder is the precursor to psychopathy. So, not all psychopaths or I'm sorry, not all people with antisocial personality disorder are psychopaths, but all psychopaths have antisocial personality disorder. Individuals with antisocial personality disorder, as well as narcissistic personality disorder, really thrive off of affirmations, feeling very important, feeling very successful. They're very charismatic individuals. So a lot of times we find that people with antisocial personality disorder become politicians, celebrities, lawyers, doctors, things like that. Borderline personality disorder is where the individual has poor emotional regulation. And so they're very reactive to things and they have very low self esteem a lot of times. And they feel emotions very out of proportion to the situations, which could lead to things like unhealthy relationships, self harm, risky behaviors, things like that. Histrionic personality disorder is where individuals really don't have a strong understanding of who they are as a person. So their personality is very flexible and they kind of become whoever they feel the people around them need them to be. Because of this, they are often very gullible. They tend to jump into very unhealthy relationships very quickly. And so, our cluster B disorders do require a lot of therapy and also a lot of monitoring just for safety issues for themselves and others. Our cluster C disorders are anxious or fearful disorders, and this is avoidant personality, dependent personality, and obsessive compulsive personality disorders, which is different than obsessive compulsive disorder. So that can be a little confusing. But with our anxious and fearful disorders, our main focus is to help them build life skills and self esteem so that they feel competent in doing things on their own. Then we have our pediatric mental health disorders. Our pediatric patients can develop mood disorders and psychiatric disorders just like our adults can, but oftentimes, if they start in childhood, the symptoms are going to be much more severe and much more pervasive. They may require more intense treatment than they would in adulthood. Um, the most common pediatric mental health disorders that we see are ADHD, which is often symboled by forgetfulness, carelessness, risky behaviors, trouble getting along with others, disorganization, excessive talking, excessive daydream, and difficulty sitting still. Our ADHD is treated with stimulants like Adderall, Strattera, things like that. And our main focus for our patients with ADHD is helping them to improve their school performance, improve their socialization, and avoiding any dangerous, risky behaviors. The other type of common pediatric mental health disorders is our autism spectrum disorders. So these are sensory perception disorders where the patient may feel hyper sensory output or hypoactive sensory input. They often have impaired verbal and nonverbal communication skills, but they still very much crave socialization. Um, they may have obsessive interests or fluctuating interests that is abnormal in their intensity. They can often engage in repetitive behaviors or activities, and they really thrive on having a very secure schedule. The autism spectrum disorders do have a wide range of intelligence from being considered less than normal intelligence to genius level. And our main focus with our patients with autism spectrum disorders is making sure that we're keeping them um, at a good sensory stimulation while providing them with good structure and preventing them from any self harming behaviors and helping them build social and communication skills. As far as personality disorders go in our pediatric patients, there's only two that can actually be diagnosed, and that's ODD and conduct disorder. And ODD is oppositional defiant disorder. And these are both precursors to antisocial personality disorder, and they have very similar symptoms. But because we can't diagnose antisocial personality disorder until after the age of 18, in children, it's called conduct or ODD disorder. And our main treatment for that is just going to be a lot of therapy. We also have attachment disorders in our children. So they can have separation anxiety disorder, where they have extreme anxiety and temper tantrums when separated from a loved one. We can also have reactive attachment disorder and disinhibition attachment disorder. And so those two disorders are very common in children that have had neglect early on in life, that have come from orphanages where they've been neglected, or maybe they come from a family of a lot of abuse. And basically, what they are is, depending on which one they have, the patient may have a hard time forming attachments, so they aren't able to form strong relationships with others, or they are the opposite, where they don't have the inhibition to know, hey, this is a stranger. I shouldn't form a strong attachment with them. So, those are two different types of attachment disorders in the pediatric population. There's also eating disorders, and the reason why I included this in the pediatric mental health disorders, even though it can also be an adult disorder, is because most eating disorders start in childhood. The most common eating disorders are anorexia nervosa, where the patient reduces their caloric intake by not eating or excessive exercising, and the caloric intake is less than normal need. With anorexia nervosa, the patients become very thin, they lose quite a bit of weight, and it can really impair their organ functioning. So their organs may have a lot of damage, they may start to shut down, they can have risk for cardiac arrest and a lot of other physical ailments. The way that we treat anorexia nervosa is through refeeding and therapy. So, with refeeding, we give them a certain amount of caloric intake per day and increase it slowly until they've regained 80% of their ideal body weight. Um, with refeeding, we really want to monitor for refeeding syndrome, which can have very deadly effects if it does develop. And our patients are also at risk for a lot of cardiac and GI issues when they're in the refeeding process. Another eating disorder is bulimia nervosa. And this is when our patients binge eat and then they feel guilty. So they find ways to purge. Purging can be through excessive laxative use, excessive exercise, or by vomiting. And so with bulimia nervosa, our patients stay at a normal weight. They don't have that extreme weight loss that we see with anorexia, but they are at risk for electrolyte imbalance, esophageal erosion, and a lot of other physical ailments as well. Again, we're going to treat bulimia nervosa with a lot of therapy. We can also provide them with an antidepressant, and we would want to encourage them to keep consistent meal times. A lot of times, what happens is if someone has a binge episode, then they starve themselves because they feel guilty about that, and then they become super hungry, and it leads to them binging again. With both eating disorders, our treatment in the hospital would be weighing them with their back to the scale. A lot of times, eating disorder units won't have mirrors. They may also have it where they're on a reward system. So if they eat their meals, a certain number of meals in a row, maybe they can have certain visitors or certain privileges. So those are two common eating disorders. There are a lot of other eating disorders as well, but they're not as common. And then we have our psychiatric disorders of the older adults, or the 3Ds, which are delirium, dementia, and depression. Depression is going to be the same as it is in the adult population, but what we find is there is a spike in depression for our older adult population. And part of that is because um, a lot of their social network and their friends may start to die. They start to have to deal with a lot of physical ailments and chronic conditions, and they may just start evaluating their life as they reach those final stages of Erickson's theory of development. Um, so we want to make sure that we're monitoring our older adults for depressive symptoms, for any suicidal ideation, and we want to make sure that we're treating that. Delirium and dementia present very similarly, but delirium is short term. It develops very quickly over a few hours to a few days, and it is reversible if it's treated properly. So, this is things like confusion, hyperactivity, disorientation, um, and a lot of common causes of delirium are things like infection, medications, change in environment, hospitalization, surgery, stress. So, the way that we treat delirium is to identify the cause and then treating that cause. Dementia is more long term and it's progressive. It develops over a long period of time, and it's a umbrella term for a lot of memory loss and loss of function to carry out your day to day activities. So, Alzheimer's disorder is actually a form of dementia, and then there's other forms like vascular dementia, Lewy body dementia, Parkinson's related dementia, Huntington's related dementia. And our main cause, or our main treatment for dementia, is going to be increased supervision, keeping them on a strong schedule, helping them retain what memory and function that they have, as well as providing them with anticholinergic medications. So, lastly, we have our substance abuse and misuse disorders. The most commonly abused substances that we see relating to hospitalization are alcohol use, opioid abuse, stimulant abuse, cannabinoids, and inhalants. Um, when we have someone that has a substance abuse or misuse disorder, a lot of times they'll get special therapy on motivational interviewing and recovery. Um, in the hospital or psychiatric facility, we may need to monitor them for things like overdose and withdrawal. With withdrawal, there's two different withdrawal scales: the CWA scale, which measures alcohol withdrawal, and the CNA scale, which measures opioid withdrawal. The way that the CWA scale works is it measures a variety of different symptoms, and based on the score the patient gets, allows us to know what treatment to follow. So, oftentimes we'll give them a benzodiazepine until they safely detoxed, and their CWA score will help us determine how much of that benzodiazepine to give. The CNA scale helps us to identify what symptoms the patients are having so that we can treat them symptomatically. With our substance abuse and misuse disorders, we do have to have very frequent monitoring. They are going to be on withdrawal precautions, seizure precautions, and we would want to really help them find a place of recovery. So, now on to communication. Communication is a huge part of the nursing process and care of patients with a psychiatric disorder. We always want to make sure that we're having therapeutic relationships with our patients and that we're having therapeutic communication. So what does that mean? It means that our communication with our patients are meaningful. It means that we are respecting our patients and that our patients respect us. It means that we're limiting self-disclosure, which means limiting talking too much about ourselves, sharing our own personal information, and that's to protect our own safety, but also to make sure that we're focusing on the patient and that the patient is getting meaning out of that interaction. So, different therapeutic communication techniques are things like silence, seeking clarification, perception checkering, um, giving information, acknowledging, using open ended questions, summarizing, reflecting, clarifying, using therapeutic touch. Um, some non therapeutic communication techniques would be things like close ended questions, giving advice to our patients because that limits their ability to make those decisions for themselves. And when we're engaging in communication with our patients, we want to be aware of defense mechanisms. So, defense mechanisms are things that the patient can do that helps them avoid either dealing with something or talking about something, and they're broken into different categories. So we have our narcissistic defense mechanisms like projection, where they project their feelings onto someone else. They may be in denial or engage in staff splitting. Um, Immature defense mechanisms are things like blocking, regression, somatization. There's anxiety related defense mechanisms like repression, acting out, rationalizing, passive aggressiveness, and then mature defense mechanisms, which we call them mature because they're more beneficial than the other defense mechanisms. And sometimes they can be beneficial in helping the patient cope. And that's things like using humor or suppression. So, when we're engaging in therapeutic communication with our patients, we want to be very aware of their therapeutic needs, their communication needs, and we want to make sure that we're offering the respect and healing environment that they need. So, if anyone has any questions, feel free to let me know. Moving forward, we have a couple of different activities that you can do to practice some of these skills. So, the first one is a communication activity. What you want to do is get into groups of 3 or 4. And in the first activity, you're going to have someone be the nurse, and then someone else will be a patient, and then the third or fourth person will be the observer, and they'll give feedback for that individual. And at this point, this activity is simulating what it may be like to talk to someone that has delayed thought process related to depression. And in delayed thought process, our patients can have um, a slower time communicating and processing what we have to say. So they may take up to 30 seconds to respond. So in this activity, the person that's the patient should time themselves and not respond to anything the nurse says for at least 30 seconds. And then I want you guys to talk about how it felt, what thoughts the nurse had, what they felt was going on, how did it feel for the patient, and how do you propose modifying the communication so that you are addressing the needs and the communication needs of someone with depression. The second activity stimulates someone that has mania. So you'll switch up who's the nurse, who's the RN, and who's the observers. And what the patient needs to do is talk very loud, fast, and without stopping, and try not to let the nurse get any words in. So for the nurse, how did that feel? What thoughts did you have? What was going on? For the patients, how did it feel? And how do you think that you should talk to someone that is experiencing hyperverbal communications and help redirect them? The third one is someone that has psychosis. So you can take a sheet of paper and roll it up, and you're going to put that paper up against the patient's ear and whisper to them as they're interviewed by the nurse. After this, you want to talk about how it felt for the nurse, how it felt for the patient, and also how it can be a scary environment for someone that's experiencing psychosis, and how it can be very distracting and hard to focus on what the nurse says, and what we can do as a nurse to help improve our ability to communicate with someone that has psychosis. And then lastly, you can mix it up so that the person starts using defense mechanisms. And again, go through the same evaluation questions. Then we have a few case studies that you can do. And these are case studies that you should apply the nursing process to. So go through, what would you assess in the patient? What are the current assessment findings? What are the potential and priority diagnoses? What are your goals for this patient? What kind of interventions would you expect, and how would you evaluate it? So the first case study is that you are caring for a 35-year-old female brought to the hospital with significant weight loss due to decreased appetite, hypersomnia, and increased forgetfulness that has caused her to miss multiple important meetings and appointments. Family reports that the patient has seemed down lately and less interested in her usual hobbies. Upon assessment, you find that the patient is disheveled, delayed in speech, and avoids eye contact. And the second case study is that you are caring for a 23-year-old patient with new onset psychosis. Family reports that the patient has been staring into space often and can be seen laughing and talking to himself. In addition, the patient has been more fixated on religion and supernatural experiences. He has implemented multiple changes to his diet, stating, "I need to purify my body to be worthy when they come to change the world." Upon assessment, the patient appears unfocused and to be responding to internal stimulation. The patient denies any alcohol use, but admits to smoking marijuana on a daily basis.